A very good morning to all. Today's topic for discussion would be regenerative endodontics. Okay, as we all know, traditionally when a patient comes to the dental clinic, when the pulp is necrotic, the line of treatment would be root canal treatment, right? And especially when it comes to necrotic pulp, necrotic teeth with the immature teeth or with open apex, then the line of treatment would be either apexification, right? So what is apexification? Apexification is a procedure done in young permanent teeth where the root apex is not closed, and therein what we do is we try to close the apex with the help of a material which is most commonly used material is MTA. We use MTA and then we try to seal the apex, and then followed by we do a backfill with the help of your guttapacha. So this has been the traditional treatment for managing the immature teeth with open apices. Now the problem is during that entire procedure, if you completely analyze the treatment procedure, then the patient has to come to us first, and then we have to do the entire cleaning and shaping, and then followed by we have to place the material, and for that material again we have to give another appointment because till the setting time of the MTA is almost around 24 hours, so we have to wait, and patient has to come for the second time, and in the second time we have to do the backfill, right? So the entire procedure, the treatment is good, but then the outcome what we are going to get is not relatable to the natural teeth. So with all the advances in endodontics, field of endodontics, right, and especially in the regenerative aspect, so now this particular aspect of apexification can be thought in the process of regeneration. So what is regenerative endodontics? So with the procedure of apexification, we are not going to get back, we are not going to aim at the increase in the thickness of the root dentine. We are also not aiming at the natural formation of the root apex. So this is the drawback of the regular apexification procedure using MTA. Now when we want the natural regeneration to take place with the help of all the materials which are available, that is called as regenerative endodontics. And so what is regeneration? Regeneration is the process of renewal, restoration and growth that makes genomes, cells, organs, organisms and ecosystem resilient to natural fluctuations or events that cause disturbance or damage. Right? Now what is tissue regeneration? So regeneration doesn't happen just because I say that it is a cumulative process, or it is a combined effort of many factors put together. It is an interdisciplinary field that applies the principles of engineering and life sciences towards the development of biological substitutes that restore, maintain or improve tissue function. Now the main aim of regenerative endodontics is to regenerate pulp-like tissue, right? Pulp-like tissue or pulp-dentin complex more precisely. So with that, what we are aiming is, so the regenerative endodontic procedures can be defined as, these are the biologically based procedures designed to replace damaged structures including dentine and root structures as well as cells of the pulp dentin complex. Now somebody can ask me, what is the importance or what is the advantage of the regenerative endodontic procedure? So when we do a normal apexification procedure with your MTA, what is happening is the tooth is being sealed, but then the patient is not getting back. The vitality of the tooth is being lost. The tooth is just merely present, it is serving its purpose, but the regenerative aspect, the pulp is vital? No, the pulp is not vital. But with these regenerative endodontic procedures, what we are aiming at is to cause the regeneration of the pulp dentin complex so that the pulp will become vital and the vital tooth will have its sensitivity to hot and cold, and that is how the longevity of the tooth increases when compared to that of the apexification procedures. Now what are the objectives of the regenerative endodontics? The regenerative endodontics, the primary aim of regeneration is bony healing. What we expect is bony healing primarily. Secondarily, what we expect is that the root dentine thickness also should increase. In apexification procedure, only the apex closes, or we seal the apex with some MTA, and you can see some bridge forming there. But here with this, the goal of the regeneration would be actual thickness, actual increase in the thickness of the root dentine, right, with the formation of dentin-like substrate, and the tertiary one would be positive vital response. So the most important goal of regeneration is the development of the positive vital response. So these are the three objectives of the regenerative endodontics. So Coming back to what factors which will help in regenerative endodontics. So regenerative endodontics is possible with the help of stem cells and growth factors, as well as the substrate or the scaffold. So all these three put together, and when I apply the aspects of tissue engineering, then that is how we get the regenerative endodontics outcome. Alright, so the regenerative endodontic procedures are based upon the stem cells, growth factors and the scaffold. When all put together, when you apply the engineering protocols for that, then we get the regenerative endodontics, right? So now, well, let us talk about stem cells. So we say that stem cells, the growth factors and the scaffold. So we will deal with one by one. What is a stem cell? So stem cell is a cell that has got a potency to divide into progeny of the cells, which can later divide into any type of cell. Alright, so stem cells are the cells which have the potential to divide into a progeny of cells, which can later divide into any types of cells. Now we can see, depending on the potency of the cell these stem cells are divided into three types, and they are the pluripotent cells, multipotent cells and totipotent cells. Now what is a totipotent cell? Totipotent cell is a cell which can develop into a complete new individual, right? And now coming to pluripotent cells, they will form into any particular cell type. For example, odontoblast. They cannot again differentiate into any other types. Whereas totipotent, it can develop an individual. That means it will have a multiple progenies in itself, and it can, depending on the placement of the cell, it can divide into any type of cell. Now coming to multipotent cells, multipotent stem cells are the cells which can differentiate but can form no other tissue. They just have the ability to differentiate, but they cannot specifically form this particular type of tissue. So those are called as multipotent stem cells, right? So now we will go into the stem cells which are used in endodontics. So the stem cells which are used in endodontics are, we have the bone morphogenic stem cells, you have periodontal ligament stem cells, you have inflammatory periapical stem cells, you have stem cells from the apical papilla, you have dental follicle stem cells, we have dental pulp stem cells, and we have the stem cells from the human exfoliated deciduous teeth. So these are the stem cells particularly which are used in our particular regenerative endodontics procedure, right? So now we can have a look at the picture wherein we can see that this is a extracted third molar, and we can see the apices are not completely formed. So this is nothing but, when you observe here, you can see when the tooth is being vertically dissected, then we can see the cross section of the pulp tissue, and we can see the apices which are bulky. So this bulky tissue is nothing but our apical papilla. So these are when we talk about these stem cells from the apical papilla, so this particular ends of the pulp tissue will have loads of stem cells. So these stem cells called as apical papilla stem cells, right? Now coming to the growth factor. So the importance of stem cells is that, so when we want to generate the growth of dental pulp like stem cells, so we want some stem cells there so that it will differentiate into to form a dental pulp, right? So that so most commonly used stem cells for regenerative procedures is your dental pulp stem cells, the most commonly used stem cells for the regeneration of the pulp-like tissue. Now next is the growth factors. So now what are growth factors? What is the purpose of growth factor? The growth factor is nothing but it is the factors which will provide nutrition and which will help. They will go and attach to the cell which is differentiating and help in differentiating into the progeny. So this is the idea of having the growth factors. So the growth factors are the ones which will go and attach to the cell and which will help in differentiation of that particular stem cells into other stem cell types, right? So depending on what we want, have various growth factors related to that. So the most commonly used growth factors in regenerative endodontics are transforming growth factor beta, transforming growth factor beta 2, so beta 1, beta 2 and transforming growth factor beta 3, bone morphogenic type 2, bone morphogenic protein type 4, bone morphogenic protein type 7, insulin growth factor and vascular endothelial growth factor. So these are the most commonly used growth factors when we want the regeneration procedure to happen. Now here also we can see when we are using the common example of the scaffold would be PRF. So in PRF, we usually see these are the various growth factors which are present. This is PDGF, stands for platelet derived growth factor. This is vegetarian endothelial growth factor, and this is transforming growth factor beta. So the platelet derived growth factor helps in angiogenesis, mitogenesis, and macrophage activation. Vegetarian endothelial growth factor helps in angiogenesis and vasculogenesis, and transforming growth factor beta helps in long-term healing. It will help in bone regeneration, also which will help in regulation of the inflammatory processes, right? So this is the some function of the growth factors, and we have also endothelial growth factor, which will help in growth, cell growth, and also differentiation, right? Now, so by far we have seen what are the stem cells, and we have also seen what are growth factors. Now we will be seeing what is a scaffold. Scaffold is nothing but a substrate or a medium wherein it is having the growth factors which are embedded within the scaffold, right? So what is a function of a scaffold? What is a requirement of a scaffold is it supports the cell organization and vascularization. It helps in proliferation and differentiation of the stem cells. It will help in faster tissue growth. It helps in providing nutrition, and also it will help in giving some mechanical and biological support during the regenerative procedures. So now you can see here the scaffold is a substrate wherein we put the growth factor as well as the stem cells. So when we put stem cells in the scaffold, what will happen? It will help in giving some mechanical support toward that, and because that scaffold is also having the growth factors embedded within itself, so the growth would be good because the nutrition provided by the growth factors are already embedded in the scaffold. So this also help in aligned regeneration wherever we want the growth to take place. So the growth will be aligned rather than scattered. So what are the various types? So we have also types in the scaffold. So we have, depending on the quality or depending on the way it is being obtained, so you have natural scaffolds and you have synthetic scaffolds. So natural scaffold material are collagen, especially the type 1 collagen, type 2, type 3 and type 4. And then we have fibrin, we have anorganic bone, we have chitosan, and we have demineralized or native dentin matrix. So these are the natural materials which are used as a scaffold, right? And we have synthetic materials also for the scaffold formation: polylactic acid, polyglycolic acid, polytetrafluoroethylene, calcium phosphate, hydroxyapatite, and more recently bioceramics. So these are the synthetic type of scaffold materials. Alright, so now we have seen, by far we have seen, so what is regenerative endodontics? In regenerative endodontics is nothing but it is accumulation of your growth factors, stem cells and the scaffold put together. Now stem cells are the ones which have the ability to divide into any other cell, and depending on the potency they are divided into 3 types. And then we have the growth factors which will help in differentiation of the stem cells, and we have the scaffold. Scaffold will act as a substrate wherein the stem cells as well as the growth factors are present, and it will help in the aligned growth. So this is about the regeneration. Now you can see in the picture here, so this is a scaffold. So a scaffold will provide nutrition to the growth cell. This is a stem cell, and you can add it to so the growth factor will come and bind to the stem cell, and the scaffold will provide the nutrition. That is how the cell differentiation, you can see here, the cell again will divide into the other side types of cells. So this is the idea of the using the regenerative endodontics. Now what are all the possible treatments what we can use wherein we can use the regenerative endodontics? So the most commonly used ones are root canal revascularization via blood clotting, postnatal stem cell therapy, pulp implantation, scaffold implantation, injectable scaffold delivery, 3-dimensional cell printing, and gene delivery. So these are the most commonly used terms or used procedures during the regenerative endodontic procedures. Now coming the most popular one, or the most common regenerative endodontic procedure where we come in daily practice would be revascularization procedure. Devascularization procedure was first introduced by Evaya in the year 2001, and later on there have been modifications of revascularization procedure, and in the year 2004 TROPE has put forward a proper revascularization protocol. So what is revascularization? So revascularization, as the name suggests, so we are trying to induce some vascularization in the root canal treatment. So the term revascularization. So where all we can indicate this particular revascularization procedure is the teeth with necrotic pulp and immature apex. Remember, all these regenerative endodontic procedures are most commonly used only in teeth with the immature apex, and that condition of whether it can also be used in wilder teeth or in necrotic teeth. So there have been many studies and they have said that regenerative procedures can also be used in necrotic pulp cases, and but then the expectancy of the outcome would be little questionable when compared to that of the vital teeth. So the indications are the teeth with necrotic pulp and immature apex, and you have skull space which is not needed for post and core. That means the tooth is the space, the structure should be intact, the coronal structure is intact, wherein we don't require the placement of the post. And then the patient compliance, the most importantly, patient has to wait for your treatment procedure, and the next is no allergy to medication. So this is the most important procedure, wherein because when we are trying to do some regenerative procedures, we aim to use certain medications for the disinfection of the root canal, so the patient should be asymptomatic, non-allergic to those medications. So these are the indications of the regenerative procedures. Now coming to the substrate, the most commonly used scaffold in regenerative endodontic procedures is your platelet-rich fibrin. Okay, but what is platelet-rich fibrin is? So when the blood from the patient is taken from the cubital fossa, the blood is collected, and when it is subjected to centrifugation, so we get something like this. So this, when the blood is centrifuged, so this is what we get. So this is the completely red blood cells here deposited at the bottom of the test tube, and you have your plasma here, right? And that is also called as platelet-rich plasma. And then you have, this is the platelet-rich plasma, and this is your platelet-rich fibrin. So when the blood is subjected to the centrifugation procedure, we get something called as red blood cells at the bottom of the cell of the test tube, and we have the platelet-rich fibrin here, and then we have the platelet-rich plasma here, right? So platelet-rich plasma was also used, but then when compared to platelet-rich fibrin, so this is called as platelet-rich fibrin. You can see here the yellow transparent substrate is called as platelet-rich plasma. Platelet-rich plasma can act as a scaffold because it is also harboring a lot of the growth factors within itself. So that is why the most commonly used scaffold is platelet-rich fibrin. Now coming to the procedure of the regenerative endodontics procedure, so what do we do when patient walks in? So how do we proceed with the case? So here, so we have 2 appointments or 3 appointments for the patient. So here, in the first appointment, what do we do? So in the first appointment, when patient comes to us, first we give the local anesthesia, and then we isolate and we do the access opening for that particular case. And then irrigation protocol, here you irrigate with 20 ml of 1.5% sodium hypochlorite for 5 minutes, followed by saline for 5 minutes. Now the concentration of the sodium hypochlorite was first analyzed. There are many studies who have compared the concentration of the sodium hypochlorite and efficacy in disinfection. So what they observed is, when we use, usually the concentration of hypochlorite what we use in general root canal is 5.25%, but when the studies have observed that 5.25% becomes cytotoxic to the stem cells. So when we are aiming at the regenerative endodontic procedure, so we want to store or conserve the stem cells which are present in the pulp canal space, so that we want to protect the stem cells in the canal space, so that later when we induce the bleeding, these stem cells can come into the bleeding point in the clot, and they start giving rise to the cell proliferation. So here, that is why the concentration of the hypochlorite has been reduced to 1.5% of the hypochlorite. And then what do we do is, after that, then we dry the canal, and then we place the intracanal medicament. So the most commonly used intracanal medicament is calcium hydroxide. So calcium hydroxide, the most commonly used, it is good enough. And the other ones also which is used is the triple antibiotic paste. So triple antibiotic paste is nothing but it is a combination of ciprofloxacin, minocycline and metronidazole. So these 3 clubbed together is called as triple antibiotic paste. So most of the people, the researchers have studied that the triple antibiotic paste will have a better disinfection, so that because we are aiming at the regenerative protocol, so we want a good disinfection to take place in the root canal space. So we can also go for calcium hydroxide, we can also go for triple antibiotic paste, and then we temporize it by placing temporary material for 3 to 4 mm, and we recall the patient depending on 1 to 4 weeks, depending on the patients, right, and depending on the symptoms also. If the patient is symptomatic, then we recall the patient, we reschedule, and then again we try to observe what is happening. Otherwise, if patient is asymptomatic, then we can reschedule the appointment within 1 to 4 weeks. Now in the second appointment, what do we do? So now the patient, so it depends on whether the patient is symptomatic, patient is asymptomatic. Now what we do when patient is symptomatic? So if the symptoms persist, then again we try to place another application of the antibiotic paste or the calcium hydroxide, your intracanal medicament, right. In case on the first go itself, if we have placed calcium hydroxide, if patient is symptomatic, then we try to place triple antibiotic paste. If triple antibiotic paste has already been placed, then we try to change the medication accordingly. So that is about if the patient is symptomatic, and then we recall the patient again. If patient is asymptomatic, if there are no symptoms, then we are good to go with the procedure, the final procedure. So in that, what we do, again we administer local anesthesia, and then we do the isolation, the regular rubber dam. After that, we try to irrigate the canal. So this is the final irrigation protocol. The final irrigation protocol should be irrigation with 17% EDTA, which is a chelating agent, and then followed by drying the canal with the paper points. And here we are not going to use hypochlorite, because again hypochlorite at the last final irrigation protocol might probably be cytotoxic to the stem cells. So that is why the second appointment we don't use hypochlorite, we only use 17% EDTA. And then next what we do is we take a 15K file, we take a K file and we try to go beyond the working length or 1 mm past the apical foramina. We take the file, we go beyond the apical foramina by 1 mm or 2 mm past the apical foramina, so that we can induce bleeding. So whenever the file goes beyond the apex, there's bleeding. So we try to go 2 mm beyond the apex, we induce the bleeding, and we have to ensure that the bleeding is filled into the cavity at the level of CEJ, right? And then what happens at the level of CEJ or below the level of CEJ, we stop the bleeding, and then we place a restorative material. So now this restorative material, again we can also place GIC, but most commonly used material would be MTA. So we seal the orifice with the we place the restorative material, which is MTA, and then followed by placement of a resorbable matrix over the blood clot, right? So this is how the treatment procedure goes in the second appointment. So first is we have to give LA, then followed by irrigation, then followed by inducing the bleeding, and then when the canal is filled with the blood, we stop the bleeding at the level of CEJ. At the level of CEJ, or making sure that we are short of 3 to 4 mm, and then we place a resorbable matrix for the blood clot. Now, for example, here we will place the rich fibrin here, and then followed by placement of either GIC or your MTA. Alright, so this is what happens in the second appointment. In the pictures we can see here, so this is the periapical area. So this is we place the file past the apex 2 mm beyond the apex, so that we induce the bleeding. Now we can see here in the picture, we induce the bleeding such that the bleeding is filling the cavity more than 2/3, and we leave this 3 to 4 mm. We place this scaffold here. For example, now we can use a platelet rich fibrin, right? And then this is a resorbable scaffold, and top of it we'll place restorative material that can be either GIC or MTA. So now we can see after this procedure, after some weeks of time period, we can see there's a growth of the lateral dentinal walls, and we can also see the apex being closed. So this last image shows that the regeneration has taken place. This is also one of the image where we can see this is the immature apex. So the mechanism would be the formation of the root end. The mechanism explained is the stem cells from the apical papilla will go into the into the root canal, and here they go into the root canal and they start differentiating and will give rise to the odontoblast-like stem cells, wherein they help in deposition of the root dentin, also form the apex. Here we can see the MTS here, and this is the coronal seal here. And over a period of time, we can see the root formation has taken place by increasing the length of the canals and also the width of the canals, right? So what are the advantages and disadvantages of the revascularization procedure is, Advantages is lowest risk of immunity, because we are not trying to put some foreign material, so there's the lowest risk of immune rejection and lowest risk of pathogen transmission, because we are just inducing the bleeding of the patient itself, so there's nothing, so the risk of transmission or rejection is completely not present. Disadvantages, because there is minimal case reports published to date wherein this particular procedures can give rise to the formation of the root apex and the potential risk of necrosis if the tooth becomes reinfected. In case if the protocol is not being followed, in case of the disinfection of the root canal has not been done, so and in case if the isolation is not maintained properly, then we can also see that the tooth also can get reinfected. So this is the major drawback of using the revascularization procedure. Here are some examples where we can see this is the mandibular second premolar. This is the intraoral image and this is the radiographic image. We can see that the image, we can see the apex is not formed, it is an immature teeth, and we can see little periapical infection there. So we can see here, so when the regenerative procedure was induced in this, so the first appointment, what we do is we only try to open the axis, we try to irrigate, and then we try to place an intracanal medicament and then close it off. And now in the second appointment, if the patient is asymptomatic, what we do is we go beyond the apex, we induce the bleeding, we place blood clot, and then what we do is we place a resorbable matrix. On top of it we place a MT or GIC, and then we seal the orifice, and then on top of it we give a permanent post-endodontic restoration, right? So over a period of time, when we observe and we recall the patient, now here we can see the same tooth with the revascularization procedure, we can see the apex being formed, and also we can see the increase in the thickness of the root dentine laterally, right? So this is the positive outcome of a revascularization procedure. So this is to summarize. First, we disinfect and shape the root canals for the regenerative procedure. In the chemomechanical debridement, we use they say that it is 6% sodium hypochlorite, but then we technically use 1.5% because we don't want the cytotoxicity to disturb the stem cells. And then the intracanal medicaments, again we can use calcium hydroxide, triple antibiotic base, and also we can use MTAD, which is a root canal irrigant, which has the medication property. And then so this helps in replacement of the pulp dentin tissues and helps in revascularization procedures. Okay, so as said, the advantages of the your regenerative endodontic procedures is that it is helping in regeneration of pulp-like tissue. It is also helping in vitality. So definitely that is more promising than replacing the tooth with some root filling material. So that is the primary and the most important procedure. And here in revascularization procedure, we are just inducing the bleeding and helping in regeneration. So that is good. Disadvantage is that we cannot be sure of the outcome, so that is a disadvantage. And also failures, in case if the disinfection is not proper, then definitely we can expect some failure.